My name is Dr. Abad Khan. I am an interventional cardiologist at St. Joseph Hospital. And with me today, we have a very important guest today, Dr. Rahul Gupta.
Hi.
He is currently the lead cardiologist in Apollo Hospitals, Navi Mumbai, and the visionary for the CRISP conference. He's an extremely passionate person about interventional cardiology, but especially about the structural interventions, specifically TAVR. So today, we'll be discussing a few things and hopeful to get a good, clean answers also. So Dr. Rahul, with the latest trials and a lot of trials coming up in the field of structural interventions, particularly TAVR, the SMART, and all those things. How do you see TAVR evolving in India for the next 5 to 10 years?
I think, as we all know, TAVR has become the passion and the hot flavor of the season. Everybody wants to learn TAVR. That's a very good thing. But the TAVR, which began from very high risk population to high risk to moderate risk and now to low risk, there would be further evolution. That is what I feel when I look into the field of structural cardiology, because there are a lot of innovations which are happening in this field. The device profile is becoming smaller, so we will be able to deal with a lot of complex anatomies. The material of the valve is changing so that the longevity increases. The complications related to the TAVR, whether it is the need of the pacemaker, whether it is a paravalvular leak, the material which is being used will reduce all these things. So when this happens, the indication of TAVR is going to further increase. Look at a scenario where the TAVR valve can work for 20 years. Absolutely desirable result without less complications. The TAVR indication would increase to much lower age. Now there are certain trials which are happening in patients who are severe AS without any kind of symptoms. It is also expanding in certain fields, certain trials where the moderate aortic stenosis, the concept is coming up, it's building up, that why to wait for the structural changes to happen in the heart which are irreversible when the AS becomes severe, rather when it is moderate and where there are not much structural changes. These are the fields which are being explored, because once the longevity increases of these valves and when the complications rate further decreases, I think these are the areas where the expansion of TAVR valve will further go. Plus, if you look at in the field of AI, aortic incompetence or aortic regurgitations, where we are still lacking, we are still doing off-label use, but this indication, as we know with the J valve, the GINA valve, all these valves which are being used in aortic incompetence, so indication of TAVR will also increase into the aortic regurgitation field. The cost of TAVR is static. The per capita income is increasing. So we are going to see a huge population base which each one of us will have to deal with it in future, and therefore it is high time that we enhance our knowledge in this field, because we are going to face these patients a lot in our day-to-day practice, and therefore you see the interest is right. There are a lot of people who are now interested in attending these kind of conferences where they can continue to build up their skill, so that when the D-Take comes, when the procedure comes into their cath lab, they are able to deal with confidence. So the TAVR indications are going to increase. The TAVR age might go down, and therefore the population base, the affordability will increase, the device cost will go down. So we are going to see a lot of TAVR in each of the cath lab as we are seeing coronary interventions these days. So this is my feeling about the TAVR in future, in next decade in our country and as well as everywhere in the world.
Besides TAVR, what else lies for other valve problems? What about the other forgotten valves like the mitral valves and especially the tricuspid valve?
Yeah, so
what lies ahead in structural intervention?
As you rightly say, I think there is already a lot of expansion of various valves intervention. So we have seen TAVR. We know the market of aortic valve disease. Just to tell you, market or the patient population of the mitral disease is much, much higher than the aortic valve. The only issue is with the mitral valve apparatus and because it's the kind of configuration which we have, that a lot of devices are there in innovations where we will be able to deal with the mitral, the native mitral valve. Right now we know that valve-in-valve is very much possible and is being done quite significant numbers, where there is already a tissue mitral valve which is surgical valve and where we are replacing and doing a TMVR, and we are doing TMVRs in MAC. But there are valves which are being innovated, which are already there in the trials, where we will be able to replace the mitral valve, native mitral valve, quite safely. We already know about the regurgitant lesions, where we are using Mitra clip, the Pascal device, where we are treating severe mitral regurgitations. There are other devices which are going to come, which Indian companies are innovating, and therefore the indications for mitral regurgitation treatment and the patient population and the affordability is going to be there, so that these interventions are also going to increase in our lab. We have the tricuspid valve, as you were saying, it's a forgotten valve. There are a lot of data that tricuspid valve, if left untreated, then you can reach a point of no return where you can't give any meaningful treatment to these patients. It was a forgotten valve, it was an orphan valve, you can, as you rightly said. So we already have some tricuspid valve interventions. We have the bicable valve, we have TriClip, then we have the native valve replacement, the Evoke valve, which is already now US FDA approved, and we will be seeing in near future, which will be there in our country to be dealt with. So a lot of innovations are happening. We have the pulmonary valve implantation, which is already happening for those adult TOF who have got severe PR. So these indications are already there. Again, as I'm telling you, as the affordability increases, as the knowledge increases, as the more and more devices will be available which are there in the pipeline, this portfolio of structural heart intervention is going to increase significantly. Similarly, we have these non-valvular interventions which will also pick up. They are already there, LA appendage closures, the paravalvular leak closures, and all those things which all of us will have to learn, because as we deal with structural transcatheter intervention in the structural heart disease, all these issues we are going to face, and then we will have to deal with it. So I see a huge need to learn all these techniques so that we are prepared when we actually have these cases.
For this, all these structural interventions to learn. And the last question is on these lines only. Why a new cardiology conference when there are so many already cardiology conferences in India, international also? What's there different to learn for the young age cardiologists as well as for the old age cardiologists from this conference, CRISP 2024?
Looked into that why there is a need of another conference and this type of conference which we are trying to do it. So here our focus is going to be on discussions, on dialogues, on interaction. So speaking time is going to be limited and there is going to be a lot of discussions, because what we realize that this is one need gap which is there, where we go to the conferences and there are so many speakers, we are already late, so the discussion time is cut. When the speaker overshoots, your discussion time goes off, and discussion is a very important time because that's the time where you clear your queries. In the talk, you are just listening to the speaker, and during the discussions, you clear your queries. So we have tried, and we will be doing in this conference is keep the discussion time intact so that all the queries are answered. We aim that none of the queries should be unanswered, and that is what will make this conference a lot of different from most of the conferences. Second, we have been discussing, so the entire core team and the other colleagues which we have been discussing about how to control or moderate the content even before there is a discussion. So we have created a lot of burning questions, and these burning questions are not just from me or from few of the people. We are taking these burning questions from different levels. So the burning questions coming from who is freshly passed out or who is recent into the practice, somebody who is into the mid practice, and somebody who is already quite senior and they still have certain burning questions. So we are already collected a lot of burning questions which are being sent to the speakers, that please answer these questions during your talk, so that most of the things are already answered and whatever remains will be answered during the discussion. So that way we'll have the content which is already answering the lot of questions for most of the people who are attending as the delegate.
What does a new age cardiologist and an old age cardiologist benefits from this conference?
Yes. So this is again that how can it cater to everybody's need? Now the new age cardiologists who are recent into their practice, I think they are going to benefit immensely, because all the seniors who are going to come, who have 20, 25, 30 years of practice, these are the people who are going to participate in the moderation, interaction, discussions, and hear from them their own personal experiences, because that's what is not there in the books. And these small tips and tricks which we can get from the seniors is going to immensely benefit recently cardiology brigade and coming to people who are already seniors. So, it's basically we are going to learn from them.
Absolutely.
But then there are a lot of newer technologies which we were discussing about the structural heart interventions, which is new for everyone. So it is new for the seniors as well as it is new for recently passed out. So when these talks are going to happen, it's going to benefit even our seniors who are going to attend this conference. And because there are a lot of discussions which are going to happen, they will also pick up those points. And the good part is when the seniors who already have experience and when they are looking at the newer technologies, they will be able to combine their wisdom of so many years into the newer informations, and their discussions is going to enhance the overall knowledge acquisition by each one who is attending this conference. So I think it's going to be fantastic, and it is going to be a conference with difference. It is going to be a conference where we are going to create, which we are already in the process of creating, the consensus about each and every topic. So when we are dealing with the gray areas, or when we are dealing with any particular topic, we are not left confused after the speech and the discussion is over. So we are going to give crisp consensus about each and every topic which are in our day-to-day practice, rather than discussing on the statistics and all, which is important to know. I say that everything is important, but here we are going to discuss with the practical day-to-day problems, so that when we go home, when we go into our war zone, which is our cath lab, we are able to deliver the best to our patients, and we all are happy when our patients are happy and when we have given the best possible outcome. So that is our particular aim. And the last thing is, as you will see, and as you must be seeing, the energy levels are going to be high. The grasp is maximum when the energy levels are high. So you will see that each one of us, all the organizers, all the moderators, all the delegates will be full of energy. And that's what we want. This is the energy which we want to bring into the CRISP conference, that everybody goes with that wow feeling. So that's what we are trying very hard to get into this kind of mode. And I think each one's contribution is going to be immensely helpful to make this conference a huge success.
Absolutely, and congratulations to Dr. Rahul Gupta, who has been the biggest brains to bring this conference, hopefully, and with the crisp ideas and crisp discussion and crisp consensus. We all welcome you to have come to Mumbai on 18th of October to come live at the CRISP conference. Thank you.
See you all over there. Thank you.